right, this is our review on hematology and oncology, which is also known as HEMOC. You'll hear that a lot, a HEMOC doctor. Those are the specialists that are cancer, but they also help people with blood disorders. Cancer is a failure of the immune system. I think I said this before when I was talking about the immune system. A lot of us will have cancer cells floating around, but our immune system recognizes it, goes after it, kills it. When your immune system fails, that is when cancer can take hold. That's why cancer is more common in older people, because their immune systems are not as strong. Cancer is a malignant neoplastic disorder that can involve all body organs with manifestations that vary according to the body system affected and type of tumor cells. Obviously, you have different types of cancer: breast cancer, lung cancer, kidney cancer. Cells lose their normal growth controlling mechanism, and the growth of the cells is uncontrolled. Typically, after a certain number of days, cells are pre-programmed to self-destruct. When they lose that self-destruct mechanism, they just keep growing and multiplying, and next thing you know, that's how you have a tumor. Metastasis, also known as METs. When you hear people talk about METs, it's basically cancer cells that have moved from their original site. Different ways that they can metastasize. You've got local seeding, with distribution of shed cancer cells. A lot of times it'll just be look like almost like snowflakes in their body, and their little cancer cells just floating throughout their body. Bloodborne, that's the most common way that the tumor cells get into the blood and takes it throughout the body. Or of course also lymphatic spread when it gets into the lymph nodes. We hear that a lot with breast cancer. Cancer you can have solid tumors, which are typically associated with organs which they develop, like breast cancer or lung cancer. You can also have hematologic cancers, and those are from the blood cell forming tissues. That's where your leukemias, lymphomas, and multiple myeloma come from. Cancer is graded and staged. The grading and staging basically describes the tumor, describes the extent to which the malignancy has increased in size, involvement of regional nodes, and metastatic development. So grading classifies the cellular aspects of the cancer and is an indicator of the tumor growth. And staging classifies the severity and clinical aspects of the cancer and the degree of metastasis. So here's grading. You've got grade 1, which are your cells, they differ slightly from normal cells and are well differentiated. In grade 2, cells are more abnormal and are moderately differentiated, which is also called moderate dysplasia. Grade 3, cells are very abnormal and poorly differentiated, which is severe dysplasia. And then grade 4, that's the worst. Cells are immature and undifferentiated. The cell of origin is difficult to determine. They go and look at cancer cells and go, oh yeah, this is breast cancer, or this is ovarian cancer. They can tell where those cells originate. When it's grade 4, it's very difficult to determine where the cell originated. We have staging. This one we're more familiar with. Oh, stage 1 cancer. He has stage 4 cancer. Stage 0 is carcinoma in situ. It's basically right within the organ that it's invading, like breast cancer. It would be just in the breast. Stage 1, it's limited to the tissue of origin, localized tumor growth. Stage 2 is when it's spread, but it's still within that same regional area, that same area. Stage 3 is when it has started to spread throughout, maybe to organs close by. And then stage 4 is when it's basically throughout your whole body. That, of course, is the worst, when you've got cancer throughout your entire body. Common sites of metastasis. It's interesting how different types of cancer they spread to different areas, and it's kind of predictable. Um, it's really strange how that happens, but bladder cancer typically goes to the lung, bone, liver, pelvic, or retroperitoneal structures. Brain tumors stay within the well, they don't stay, but it's usually within the central nervous system. Breast cancer goes to the bone, lung, brain, and liver. Colorectal cancer goes to the liver, lung cancer, brain and liver, prostate cancer, bone, lung, liver, kidneys, testicular cancer, lung, bone, liver, adrenals, retroperitoneal, lymph nodes. Different things that influence your cancer development. Um, chemical carcinogens. If you are susceptible, or if you are being if you're around different chemicals. You hear a lot of people that have, oh shoot, what's that? It's escaped me. I'm trying to think of the name of, like black lung. I think black lung was one of them. That's not the one I was thinking about, but that is one of them. But industrial chemicals, drugs, tobacco. We all know tobacco. That's the chemicals in that are very bad for you. Physical carcinogens, that could be radiation. It could be diagnostic radiation or therapeutic. That's why like X-ray techs wear that little badge that shows how much radiation they're exposed to, because they have to keep track of that, because if they have too much radiation, they could develop cancer. UV radiation, that's where you get it from the sun or the tanning beds. Chronic irritation. You have chronic irritation in an area, and those cells have to keep regenerating to repair the damage. Eventually that cell regeneration is going to go astray, and it's going to cause it's basically a cell mutation. People that that chew the inside of their cheeks when they're stressed, I'm guilty of that. That puts me at a higher risk of developing cancer in my mouth, because those cells have constantly had to regenerate where I have chewed on the inside of my cheek. And tissue trauma. Viral carcinogens, those are different viruses that are able to cause cancer. Epstein-Barr virus, hepatitis B, human papillomavirus. Now that one is the one we're really familiar with, HPV, because now they're starting to give people a vaccination for HPV. It started off giving it to just young girls that were like 11 or 12, and then they started increasing the age of giving it. Now I think they even give it up into the 20s, and now they're even giving it to males, because HPV is a sexually transmitted infection. And there's different types of HPV. They have different numbers. There's different, but there's some of them that can cause cervical cancer. Also, Helicobacter pylori, H. pylori infection. You can increase risk of gastric cancer. Obesity, dietary factors also will make you susceptible to cancer. Different preservatives. They put all kinds of preservatives and crap in our food, and we don't know what it is, and we don't know what it's going to do to our bodies. There's a lot of theories that is causing a lot of the cancers these days. Contaminants could be even from the pesticides that they put on our food before it comes to us. Additives, alcohol, nitrates. You also can have a genetic predisposition. You think about like the BRCA gene for women that are susceptible to breast cancer or ovarian cancer. So often if you have a family member that has breast cancer or ovarian cancer, then you want to go get tested to see if you have a BRCA gene. And then well, I know like Angelina Jolie, her mother died of ovarian cancer, and she went and got tested, found out that she was positive for the BRCA gene. So she went ahead and had a hysterectomy, and she had bilateral mastectomy as completely prophylactic prophylactic. She did not have cancer, but she knew that she had that genetic predisposition, and she went ahead and basically took radical changes to make sure she didn't get it. Advancing age, we already talked about that, how your immune system is it's not as good when you get older, so you are more susceptible to cancer. And then, of course, immune function. That kind of goes even with the advancing age. But immunosuppressed individuals. People with AIDS, you see a lot of people with AIDS have cancer. Again, it's not the AIDS that kills people, it's the infection. It could be cancer, it could be pneumonia. Or look at that, an organ transplant recipient. They have to take those immunosuppressive medications for the rest of their lives. Now they're basically, they may have a nice new organ, but a new liver or a new heart, but now they're putting themselves at risk for developing cancer. So the biggest thing that to survive cancer is detection, early detection. Early detection is key. So that's why mammograms are really important to get, ladies. I believe it's at age 40 when you start, you're supposed to get them annually. Get a pap test, your pap smear. Those check for cervical cancer. I think it's at 3 years now. If over the age of 50 or 60, maybe 60, it goes to every 5 years. So that gets better. Rectal exams, check your stool for occult blood. Now, they say, at 50, start having your colonoscopy. It's every 10 years, the colonoscopy to check for any colon cancer. What's really awesome now is there's something out called Cologuard. I don't know if y'all have heard about this or not, but it's basically a little it's a kit that people do from home. It's called Cologuard. And they put a little bit of a stool sample onto, I guess it's like a little, I think it's like a piece of almost like cardboard or paper, but they put a stool sample on it and then send it off, and it's checked for a lot of things, but obviously for blood, but it can also detect cancer cells. So it's a really good pre-screening. If people then of course test positive on that, then they'll need to go and have a colonoscopy. But this is so much easier because people hate getting colonoscopies and they don't go and get them regularly. And this is really good because they can just do it in the comfort of their own home. Sigmoidoscopy, breast self-exams. Ladies, make sure you do your breast exam every month. Try to do it at the same time every month. Just do it when you're in the shower. When you're washing, make sure you put one arm up in the air. Testicular self-exam. Gentlemen, you need to be checking your testicles every month. Skin inspection. Skin cancer is huge, especially we live here in Florida with this nice bright shiny sun. So check your skin. Check your skin for any moles that have changed. If you've had a mole your whole life, it stays the same, great. But if it starts suddenly changing, especially if it has irregular borders, that's a really big thing. When it has irregular borders, that tells you that there's a problem. Cancer warning signs, we use the acronym CAUTION. CAUTION, that helps you remember what you need to look for. C is for the change in bowel or bladder habits. A is any sore that does not heal. That's a big one. I mean, we know diabetics, they have sores that don't heal, but that's still, it's something that you need to keep your eye out for. U is for unusual bleeding or discharge. T is thickening or a lump in a breast or elsewhere. I is for indigestion. O, an obvious change in a wart or a mole. And N is for nagging cough or hoarseness. So diagnostics for cancer. They can do biopsies. Usually that's what they'll do, is go in and even a skin, they'll take a little biopsy, or any kind of tissue. You've got a spot on your liver, they're going to go in and probably do a needle aspiration and do a biopsy on it. Bone marrow examination, chest radiograph, a CBC, a CT, cytology studies. That's for the PAP. Even PAP smear stands for papinocolaui. Yeah, pap smear. Um, Evaluation of tumor markers. You have liver function studies, MRI, PET scan, proctoscopic exam, radiographic studies like the mammogram, and radioisotope scanning. Pain control for a cancer patient. Causes of pain is, basically the obstruction of an organ, bone destruction. It can be compression of nerves, inflammation, necrosis. It could be psychological. They're scared. Fear and anxiety. That makes you more sensitive to pain. Notice in red letters here, because this is huge and this is something I am very passionate about. Pain is what the patient says it is. Do not under-medicate the cancer patient who is in pain. My sister had endometrial cancer. Approximately 2 months before she died from it, took her to Mayo, to the emergency room. She was in horrid pain, and a nurse practitioner came in and made a comment about, well, we're not here just to, give out drugs. And that set me off. My sister, like I said, was within months of dying, and I went after her and basically was like, you need to go read your notes and read, because she was a patient of Mayo. She was doing some experimental treatments there. I was like, you need to read your notes before you make comments like that. She disappeared. I didn't see her again the rest of the time. I think she was embarrassed, and she should have been. Some pain interventions. Collaboration. Develop a pain management program. You always want to collaborate with the physician, the oncologist, and maybe the primary care doctor and the nurses. It is a team effort. Administer oral preparations if possible, but you can also do transdermal, transmucosal. Transdermal, like the patches, like a fentanyl patch. Mild or moderate pain can be treated with salicylates, acetaminophen, and NSAIDs. Severe pain is treated with opioids. Neuropathic pain, gabapentin. Even though gabapentin was originally developed for seizures, they found that it had a lovely little side effect of helping with neuropathy. So I see more people on gabapentin for nerve pain than I do seizures. Also, some antidepressants actually help with neuropathy pain. Some non-pharmacological techniques is distraction, relaxation, guided imagery, massage, aromatherapy. So surgery for cancer, sometimes it's used to diagnose, sometimes it's used to actually stage the cancer, sometimes it's used to treat the cancer, sometimes it's just used to improve the quality of life. So you have prophylactic surgery. That's when you have an existing pre-malignant condition or a genetic mutation. Just like I was just talking about, Angelina Jolie went and had hysterectomy and had mastectomy because she was strongly predisposed to the development of that cancer. Curative surgery, that's where they can actually go in and remove the entire tumor with the intent to cure the patient. A control surgery is also called debulking, where they go in, and if the tumor is really large, they'll go and take out a good part of it, as much as they can. Sometimes it's, there's a lot of nerve involvement, so they get out as much as they can, and then the patient will have to go through either radiation or chemotherapy to destroy the remaining tumor. Palliative, that's where you have the surgery that improves the quality of life. They want to, could be that they're having pressure on a certain nerves, or they could have obstructions. So this surgery it's not to cure them, it's literally just to make their life more bearable. And then reconstructive surgery. That is very common with like breast reconstruction after a mastectomy. They used to do it completely separate. They would do a mastectomy and then later, a couple months later, do a reconstruction. And they still do that in some cases. I know someone recently that had separate surgeries. But also, I've seen it all done at one time. They will remove the breast and then do a reconstructive surgery at the same exact time. So the treatment, obviously we all know chemotherapy. Chemotherapy is for systemic. That means when it's throughout their whole body. Radiation is it's more focused. If the tumor or the cancer is localized in one area, you can put radiation on that spot to destroy the cancer. Now you have to remember, radiation and chemotherapy, it doesn't know the difference between cancer cells and regular cells, so it just kills cells. Radiation, it's just going to kill all the cells in that area. My mother had nasal cancer. She had radiation done on her nose. Well, it ended up affecting all of the cells in her her mouth. She ended up losing some teeth. She had like swelling in her mouth. She looked like she had a sunburn. Her tear ducts, she had problems with them where they actually constantly run. So it affects a lot of different things. Now they have proton therapy now, which the nice thing about that is it's radiation, but it's very pinpoint, and they are able to go in and literally put it right on the cancer cell and zap it with radiation and preserve those healthy cells surrounding it. Proton therapy, we have quite a few places here in Jacksonville that do proton therapy, which is really interesting because me being here in Jacksonville, I just assumed it was everywhere. And my sister lived in North Carolina, and I had made a comment to her physician that maybe we should try proton therapy. And she said, yeah, that's a great idea, but we don't have it anywhere. The closest place is Jacksonville, Florida, which I thought was really funny since here we were in North Carolina. And I was like, oh, well, that's actually how my sister ended up down here for treatment. Chemotherapy, that's when you can't just irradiate one particular area. Sometimes it gets to point like it's almost like a snow globe. Shake up a snow globe and you got all those little things floating around. People have cancer cells floating throughout their whole body. That's when they have to have the chemotherapy. It is systemic. It can be done via IV, where they go in and have their chemo treatment. There's some even where people drink it, or even a pill. There's even chemotherapy pills that some people take. There's also hematopoietic stem cell transplant. Those are the bone marrow transplants. And that's when they go through and replace like stem cells that have been destroyed. So that's more common in leukemia and lymphoma, or even multiple myeloma. Because those are all blood cancers. So that's one of the treatments there. Chemotherapy is pretty rough on your body. Kind of going back to that. Again, I said that even normal cells are affected. Normal cells such as your skin, your hair, your lining of your GI tract. Now that's why people lose their hair. That's why people have problems with their GI tract, why they have the vomiting, nausea and vomiting, because those cells have been killed as well. Pretty much so for any of these cancer treatments, you're going to have fatigue, a lot of times nausea and vomiting. You are also going to be immunosuppressed because you're having all these cells killed off, and it is going to make you immunosuppressed. And that's why people with cancer, sometimes they may need to be put on neutropenic precautions, which we talked about in class the other day. That is when you don't really want them around children. If anybody around them needs to be wearing a mask. No fresh flowers, no fresh fruits or vegetables. They shouldn't eat any of those because of the bacteria that could be on it. All right, leukemia is one of the blood cancers. A lot of people say, oh, I had blood cancer, or I have a relative died of blood cancer. Well, blood cancer is leukemia. It's basically, and leukemia is kind of like an umbrella term. There's a lot of different subsets underneath it, but it's basically a group of hematological malignancies that involve abnormal overproduction of leukocytes, usually at an immature stage. So it's kicking out these leukocytes, which you think, oh, yay, great, that's going to help the immune system. Not when they're kicking them out so fast that they're immature. When they're immature, they're no good. They're not going to help at all. And so now you're going to have your body full of these leukocytes that are not able to protect you. If any of y'all ever heard the term a shift to the left, a lot of times with lab work and stuff, they'll say, oh, they've had a shift to the left. And that literally is talking about the development of that blood cell. That a shift to the left means that it's immature. It's not a normal blood cell. Typically, the cause is unknown, but it's usually, they believe, genetically damaged cells. Signs and symptoms, they're fatigued, they have weakness, weight loss, anemia, overt bleeding, ecchymosis. Do y'all know what ecchymosis is? Ecchymosis is just a fancy word for a bruise. I had a nursing instructor that used to call them Eskimo kisses, and so my kids were raised calling bruises Eskimo kisses because ecchymosis, Eskimo kiss. Yeah, now you'll remember what an ecchymosis is. Petechia, those are those little pinpoint red dots, basically of blood that will show up like on your skin. People will have like little pinpoint red dots. Prolonged bleeding, enlarged lymph nodes, enlarged spleen and liver. They're going to have bone pain, joint swelling. They're going to have decreased hemoglobin and hematocrit levels and decreased platelet counts. They'll have palpitations, tachycardic, and headaches. Honestly, the bruising that's a big thing that parents, it usually catches their eye when their kids are suddenly bruising really easy and they have bruises all over their body. That's typically a sign you better go get things checked out, and it could be leukemia, or it could be your kid is just not very. So there's different types of leukemia. You'll hear a lot of times people talk about ALL or CLL or AML, CML. Acute lymphocytic leukemia, that is, if you're going to have leukemia, that's the one to have. It has the highest survival rate. It affects the production of the myeloblasts, which are the precursor to white blood cells that can either mature into either neutrophils, basophils, or eosinophils, red blood cells and platelets. So ALL affects all of the production of that. Mainly the production of lymphocytes. Again, that's the highest survival rate. Chronic lymphocytic leukemia, acute myelogenous leukemia, that one is the most fatal. So you can think of like the different acutes. One acute is the most highest survival rate, and the other acute is the most fatal. So that is one way to help remember that. Now, these different types of leukemias, I have a chart. Here we go. So this chart shows the different types of leukemia, how it looks, what causes it, the etiology, which cells are involved. You'll see that demographic, the first one, ALL, which fortunately is the most survivable one, that mostly affects children. Then you've got the one that's most fatal. Notice that one mostly affects adults. So check out this chart, read through it, because it's pretty interesting. All right, with leukemia, obviously infection control is big. Hand washing, aseptic technique, monitor their white blood cell neutrophil counts. Neutropenic precautions, I talked about that. Infection is a major cause of death in the immunosuppressed patient. People that have cancer or obviously AIDS, I've said this like 3 or 4 times about the AIDS patient, but even cancer. Cancer patients that are recovering but they're immunosuppressed, they end up can get an opportunistic infection and die from that rather than the cancer, which kind of sucks. You want to check them for a risk of bleeding. You want to tell them that they need to use an electric razor to minimize their bleeding. Keep an eye on their lab values. Injury prevention, so you need to educate the patient on this, and then handle them gently when performing procedures. Remember, they bruise easy, so you shouldn't be like flopping them around. You shouldn't do that anyway, but definitely with a leukemia patient. Here's lymphoma. With lymphoma, you have Hodgkin's or non-Hodgkin's, and it basically depends on the cell type. Hodgkin's is a malignancy of the lymph nodes that originates in a single lymph node or in a chain of nodes. You'll have like some lymph nodes that just kind of are all connect together like a chain. The Mets invade non-lymphoid tissue, and it usually Mets involves tonsil, spleen, and bone marrow. The prognosis completely depends on the stage of the disease. Signs and symptoms: fever, malaise, night sweats, enlarged lymph nodes, enlarged spleen and liver, presence of Reed-Sternberg cells in the lymph nodes. So that's one of the things that that would be done as a diagnostic, would be to look at the lymph nodes, see what kind of what's going on there, what kind of cells. Interventions: earlier stage are treated with radiation of the lymph node. Later stages, you need to use chemotherapy. Multiple myeloma, that's another blood cancer. That one originates in the plasma cells. This disease develops slowly. The cause is unknown. People will have bone pain because, look, it ends up with this proliferation of plasma cells. Tumors develop inside the bone. So if you think about that, you got a tumor in your bone, that's going to make your bone weak. It's going to fracture easily, and it's going to hurt. So they'll have bone pain, especially in their pelvis, spine, and ribs. They're going to have weakness and fatigue, osteoporosis, kidney failure, and spinal cord compression. Interventions: you want to support them to prevent bone fractures. Encourage fluid intake to prevent hypercalcemia. Now, why would they have hypercalcemia? Think about it. Where's calcium? Now you've got bone being destroyed. Where's that calcium from the bone going to go? It's going to go into your blood, isn't it? Hyperuricemia, same thing, and proteinuria. Monitor for signs of kidney failure. You may want to give them biphosphonate medications. Remember, those are what's used for people with osteoporosis. It helps reduce the bone destroying cells so that the bone forming cells form more cells than are being destroyed. All right, testicular cancer. We talked about that. Just like women check their breasts every month, men need to be checking their testicles every month. Average age of diagnosis is 33. This typically does occur with younger men. So any young men listening to this, take note. The Mets will go to the lung, liver, bone, and adrenal glands. It's via the blood, and to the retroperitoneal lymph nodes via the lymphatic channels. Early detection, that's huge. It's painless testicular swelling and palpable lymphadenopathy. Interventions, again, is radiation. If it's just localized, if it's systemic, chemotherapy. Sometimes you may need to have a unilateral orchiectomy. All right, pull out your medical dictionary. What does that mean? That means they may need to have one of their testicles removed. One other thing about that is if you have radiation to your testicles, you're probably going to lose the ability to have a child. So they need to possibly store up some sperm, like have it in a sperm bank for later use, or just think about other options they may have to plan on adopting children. Cervical cancer, this is what we talked about, the HPV causing cervical cancer. It's limited to the cervix. If it is invasive, it's usually confined in the pelvis. Cigarette smoking, multiple sex partners, but HPV is the big thing now. And now that a lot of people are getting vaccinations for this, hopefully this will eventually become a thing of the past. I do know there's a lot of people out there that don't believe in it though, so maybe not. Signs and symptoms: painless post-menstrual and post-coital bleeding, pelvic, lower back, leg, or groin pain, weight loss, and hematuria. Interventions could be cryosurgery, laser therapy, conization, hysterectomy. Conization, that's where they kind of go in and basically cut out like a little cone out of the cervix and remove part of the cervix. Cryosurgery, that's where they freeze it. Some people say, oh yeah, I had to have my, have it frozen. So they'll go in and freeze a portion of it. Ovarian cancer. This cancer grows rapidly and it spreads quickly. It's often bilateral. Problem with this cancer, it's deadly because early stages is asymptomatic. It usually is not diagnosed until it's in the advanced stages. It has a higher mortality rate than any other cancer of the female reproductive system. Signs and symptoms are abdominal discomfort or swelling. Often, women start feeling just kind of bloated. GI disturbances, dysfunctional vaginal bleeding, and of course an abdominal mass, and an elevated tumor marker. CA-125 is a tumor marker for ovarian or endometrial cancer. Typically you should have a 0 CA-125, but when you do have ovarian or endometrial cancer, that count will go up. And that's also how they would tell to see if the treatment is working, because that CA-125 number will start coming down. Interventions: radiation if it's stage 1, but most usually have to have chemotherapy because they don't discover it until it's already throughout the body. Total hysterectomy and bilateral salpingo-oophorectomy. Basically that means fallopian tubes and ovaries taken out, and uterus. Endometrial cancer. These two look very similar. Often you don't even really know the difference until they do like a biopsy and then they look at the originating cell. It's a slow-growing tumor associated with the menopausal years. The Mets go through the lymph system to ovaries, pelvis, it ends up in the lungs, liver, bone, or within the peritoneal cavity. Risks are hormone replacement therapy, nulliparity. Y'all know what that is, right? No babies. Never had a baby. PCOS, increased age, late menopause, a family history, obesity, hypertension, diabetes mellitus. Signs and symptoms are abnormal bleeding, especially in a postmenopausal woman. Vaginal discharge, low back pain, pelvic abdominal pain. Pain occurs late in the disease process. Unfortunately, my sister was having abdominal pain, and that was how it was discovered. She went and had a CT and was full of Mets, and unfortunately, I think she battled it for about 3 years before it finally killed her. Interventions: chemotherapy, anti-estrogen therapy. This is often also common in breast cancer. A lot of these cancers that occur in ovarian, the ovaries or the uterus, or in the breast tissue, they feed on estrogen. Estrogen is what makes them grow. So you want to take that estrogen away because you're basically starving your cancer cell. So women are given medications, and often they have to take these medications the rest of their life. Hysterectomy, so it's basically the same thing as with the ovarian cancer. Breast cancer, that's considered invasive when it penetrates the tissue surrounding the mammary duct and grows in an irregular pattern. The mets go into the lymph nodes. That's why a lot of women, when they do have a mastectomy, they have to remove lymph nodes, usually up under in their axillary area. Let's see, mets may also go to the, will go to the lungs, brain, and liver. There's often a genetic predisposition. Also, a risk of it would be early menarche or late menopause, nulliparity, a late first birth, and obesity. Typically, a mass is felt during a breast self-exam, a fixed, irregular, non-encapsulated mass. So, a fixed, irregular mass. Typically painless, except in later stages. You can also have skin dimpling or a nipple retraction. There's also called peau d'orange, and that's because literally the skin starts looking like an orange. It's all dimpled like an orange. Not everybody has these. These are just different signs. Interventions would be radiation or chemotherapy. Sometimes a lumpectomy, they can just go and take it out. Sometimes they have to take off the entire breast, mastectomy. Esophageal cancer. This is where the malignancy is in the esophagus. Cigarette smoking is a huge risk. Alcohol consumption, chronic reflux. See, remember we're talking about those cells that have to keep repairing themselves. You've got chronic reflux. You've got the acid going into your esophagus. It's killing those healthy cells. It's constantly having to rebuild those new cells. Well, eventually you keep rebuilding new cells, you're going to end up with a mutation. Well, not always, but it is definitely risk when you're having constant irritation. Barrett's esophagus, also vitamin deficiencies. So dysphagia, loss of appetite, and malaise. Interventions, you want to monitor their nutritional status because obviously they're not going to want to eat. Radiation, chemotherapy, and surgery. I had a patient yesterday that stage 4 esophageal cancer. However, he was pretty much so considered cancer-free, and they don't want to use the word cured yet, but they're optimistic. He had radiation done in his esophagus, but he took it one step extra, and he really went into the whole route of not eating sugar. Sugar is also cancer. Cancer cells love sugar. So if you have cancer, if you cut out sugar, you'll be in better shape because, again, you're going to be starving that cancer cell. He cut out sugar. He started taking different supplements. He started really working on his immune system, and it's working for him. Gastric cancer, that's in the inner lining of the stomach. The big risk there is H. pylori. Also, a diet of smoked, highly salted, processed or spiced foods. You think about those spicy foods, again, you're irritating the stomach. Processed foods, you're irritating your stomach. Signs and symptoms, you're going to have indigestion, abdominal discomfort, you're going to feel full, epigastric, back or retrosternal pain. And interventions, again, monitoring the nutritional status, encourage them to eat small meals, radiation, chemotherapy, or surgery. Pancreatic cancer, this is highly malignant, it's rapidly growing, and again, symptoms don't appear until it's advanced. So typically the prognosis is poor. Increased age is a risk, history of diabetes, alcohol use, history of previous pancreatitis, smoking, high-fat diet, exposure to chemicals. Signs and symptoms are going to be nausea, vomiting. They're going to be jaundice. Now remember, first place we usually see jaundice, icterus. Icterus is where? That's usually in the sclera. Usually that's the first place you'll notice it. They'll have weight loss. They'll have clay-colored stools. And it's not written here, but they'll have clay-colored stools and dark urine. That's because that bile is what makes your poop brown. So now suddenly that bile is going to be going into your urine rather into your stool. So that is classic with especially liver. Anything with liver, gallbladder, pancreas. When you start having a clay color, lighter colored stool and a darker colored urine, that right there should be a hint to you something's not right. Interventions, again, radiation if it's localized, chemotherapy, they may need to do surgery. Lung cancer, that's with the tumor in the bronchi or peripheral lung tissue. Lungs are also a common target for METs from other organs. There's different types of lung cancer. You can have small cell lung cancer, non-small cell, epidermal, adenocarcinoma, or large cell anaplastic. So you have different types of subcategories of lung cancer. Your risks of cigarette smoking, also exposure to passive smoke, exposure to different pollutants. Signs and symptoms are coughing, wheezing, dyspnea, hoarseness, hemoptysis, chest pain, anorexia, and weight loss. Interventions, you want to administer oxygen as needed, monitor their pulse oximetry, monitor the diet, of course radiation, chemo, and surgical. Sometimes if it's only in one lung, they may have one lung removed. Airway is the priority with somebody with a lung or laryngeal cancer. Always make sure that you protect their airway. All right, prostate cancer. This is a very slow growing tumor also of the prostate gland. It's very common cancer in American men, and it's very high in African American men. For whatever reason, I had a friend that actually did that as their dissertation, was the prevalence of prostate cancer on African American men. So if you're African American and you're a male, you need to make sure that you pay attention to that, especially as you get older. Having a PSA test, it's a blood test. So that's typically you'll have, when you have regular blood work, they'll look at your PSA levels, and if it starts increasing, that would be a sign that it could be cancer. Could also be BPH, which is benign prostate hyperplasia. As you get older, your prostate gets larger, so your PSA is going to be elevated. So it could be either or. Risks are, it increases in men with each decade after the age of 50. Smoking, any heavy metal exposure, and history of an STI. It's basically painless hematuria. Late symptoms would be weight loss, urinary obstruction, and pain radiating from the lumbosacral area down the leg. Interventions, you can have non-surgical, where you could do hormone therapy to slow the rate of growth. It is a slow growing tumor. So if you're 85 and you're diagnosed with it, they're probably not going to want to do anything radical. They'll probably be like, you know what, it's going to take 10, 15 years before it even is large enough to do anything. You're going to be 9,500 years old. So let's just be very conservative. And they would probably do more like hormone therapy. Radiation might be enough to kill it. If it is already systemic, you'll need chemo. Surgical prostatectomy. So they may want to go in and take the prostate out. There's different ways. It can be retropubic, perineal, or suprapubic. A cryosurgical ablation is a way. Again, remember cryo, that's freezing. So they can go in and freeze it. It's a minimally invasive procedure. Basically, liquid nitrogen goes in, freezes the gland, and then the body absorbs the dead cells. I thought I had more on the PSA. Maybe I did. Make sure you read your notes. I know I did. I think I went into more detail on I can't back up on this thing. A TURP procedure is really common with the prostate. That's the transurethral resection of the prostate, where they'll go in. They usually go up the urethra and resect the prostate. They'll cut out the cancerous parts and leave part of the prostate there. That's a real common procedure you see at the hospital. Oncological emergencies. sepsis and disseminated intravascular coagulation, which is DIC. And make sure you use the initials DIC. If you don't, people will look at you like you're crazy. DIC, if you're not familiar with it, it's a very serious condition. It causes abnormal blood clotting. It starts off as an overactive clotting issue. So it's overactive. Now you're going to have clots all over. So we know that's not good. That's going to be a lot of blood clots. But what happens is when your blood's constantly clotting like that, it's using up all of your clotting mechanisms. It's using up your platelets. So now it's used it all up, clotting where it doesn't need to clot. And now suddenly, what's going to happen? Now you're going to start bleeding, and then you're just going to be you're have patients bleeding out of every orifice. They're going to be bleeding up into their IV. They're going to be bleeding out their eyes. They're going to be bleeding out their nose. They're going to be bleeding everywhere. This is a medical emergency. A lot of people die from this. Often they'll have to have very quickly a transfusion, like a platelet transfusion, to start getting those clotting factors back into their body. They can have sepsis. That's the infection where it goes throughout their whole bloodstream. SIADH, we talked about that when we talked about the endocrine system. Spinal cord compression, hypercalcemia, we talked about that a few minutes ago. Superior vena cava syndrome. That is when your superior vena cava, that's the large vessel, that vein that you have your inferior vena cava and your superior, that pulls the blood and brings your blood into your heart. So it's if that SVC is compressed or it's obstructed by a tumor, blood flow is blocked and it's backed up into the venous system, the head, neck, and upper trunk. So you'll see like those distended jugular veins, and you'll see all the veins are just pooling with blood. Tumor lysis syndrome. You know, I've said in class, whenever we want to make corrections to somebody's body, whether it be sodium or potassium, we want to do it slow and steady. We don't ever want to do anything really fast because that throws the body off kilter. Well, the same thing with cancer. If you destroy cancer cells rapidly, when those cancer cells rupture, their internal components of like potassium and uric acid are all released into the bloodstream faster than the body can get rid of it. So now you're going to cause another situation where you're going to have hyperkalemic or hyperkalemic, hypernatremic. So that is a tumor lysis syndrome. It's basically the tumor's being destroyed and all their contents are coming out into the blood. All right, so that was it on oncology. Now the next section is hematology. So, and this one is much shorter. So hang tight. We're almost there. Basically, hematology, we're going to talk about anemia, and there's different kinds of anemia. Anemia is a condition where the blood lacks adequate healthy red blood cells, or the hemoglobin. And this can be caused by acute blood loss. It can be caused by decreased or faulty red blood cell production, or even the destruction of red blood cells. And there's, like I said, several different types of anemia. And the treatment is going to focus on treating the cause. With anemia, people are going to have a lot of fatigue. They're going to be weak. They're going to be pale, short of breath, chest pain, tachycardic. So we want to administer blood products or hemopoietic medications. We want to encourage a diet rich in the deficient nutrient. It could be iron, could be folate, could be B12. They may do that either through their diet or even through supplementation. These are the different types of anemia: iron deficiency, vitamin B12, aplastic, folate deficiency, sickle cell, and thalassemia. Iron deficiency anemia, this is often caused by blood loss. It could be a female that is having problems with their period, and you hear them say, I bleed all the time. I've been bleeding for 3 weeks straight. I never stop bleeding. They're usually anemic, and they're anemic usually with this iron deficiency anemia. Excuse me. This is when the iron stores are depleted, resulting in a decreased iron supply for the manufacture of hemoglobin in red blood cells. I'm going to drink some because I can't talk. Okay. They're going to be pale, weak, and fatigued. They're going to have a low H&H. Interventions are going to be, they need to increase their oral intake of iron. They may even need an iron infusion. In the hospital, many a times I've even just pushed iron into an IV. It's thick, it's really dark. You have to be careful not to get it on things. If they drink liquid iron, they need to use a straw because it will stain the teeth, and they need to brush their teeth immediately afterward. Infusion, an iron infusion, there are infusion centers popping up all over the place now. I know there's one over by Town Center. It's, they advertise it for people with hangovers, saying, oh, you have a hangover, come here and get an infusion. They basically give them a banana bag, which, if you don't know what that is, I always say it's kind of like Gatorade in a bag. But those infusion centers can be used for other things as well. And some people's iron is so low, they really need an infusion. If you're going to take iron orally, you need to make sure you take it in between meals to increase the absorption. You should take it with vitamin C, also to increase absorption. You don't want to take it with calcium or any kind of milk because that's going to put like a coating on your stomach and it could decrease the absorption. You need to make sure that the patient knows that taking iron will cause their stool to be black. They're probably going to be constipated. Also, oral iron gives you like a foul aftertaste. You kind of taste it. You taste that iron taste in your mouth. It's kind of gross. We have vitamin B12 deficiency. Now, this is either from an inadequate intake of vitamin B12 or it could be a lack of absorption from the intestinal tract. I had a patient just the other day that she'd had her entire large intestine removed due to I think she had ulcerative colitis. I don't know. She had something, but they took out her whole large intestine. She had a B12 deficiency because she was not absorbing it because obviously the large intestine was no longer there. Pernicious anemia results from a deficiency of intrinsic factor, which you need to absorb vitamin B12. Also, it could be from gastric disease or certain kinds of surgery. Bottom line is, again, they're going to look pale, fatigue, weight loss. They have a smooth, beefy red tongue. A smooth, beefy red tongue is a hallmark sign of B12 deficiency. So obviously they need either B12 injections or they need to increase their B12 rich foods, probably both. B12 rich foods, those are different things that are meats and poultry, fish, eggs, dairy products, citrus fruits, green leafy vegetables, nuts, and liver. A folate deficiency anemia. This is anemia where the red blood cells are larger than normal and are oval shaped, more oval shaped rather than round, due to the inadequate intake of folate. Folate is also vitamin B9. It could be dietary deficiency. It, again, could be malabsorption issues like celiac or Crohn's. Here it even says small bowel resection, chronic alcoholism, or chronic hemodialysis. So again, they're going to have a smooth, beefy red tongue, pallor, fatigue, weakness. You want to, again, replace the folic acid. So they could have folic acid supplements or they need to eat folic acid rich foods, which again are green leafy vegetables, beef, liver, fish, legumes. Now you remember, think about this. You got to pay attention to what other meds they're on because you don't want to give somebody that's on Coumadin, tell them to increase their green leafy vegetables because now you're going to, that's the antidote for Coumadin, right? All right, we're almost there, almost done. Aplastic anemia. This is a deficiency of the circulating erythrocytes and all other formed elements of blood due to from the arrested development of cells within the bone marrow. This is actually where these cells are just not being made. It can be congenital, Could be from a chronic exposure to toxins, viruses, or infections like hepatitis, Epstein-Barr, or autoimmune disorders. It's diagnosed by a bone marrow aspiration. The assessment would be, you would see they're deficient of erythrocytes, leukocytes, thrombocytes. They're going to have petechia, bleeding, pallor, and fatigue, and interventions would be a bone marrow transplant. All right, sickle cell anemia. Sickle cell anemia, I know y'all know this backwards and forwards, but it's an inherited condition, causes red blood cells to become misshapen and break down. The red blood cells, they contort into a sickle shape, and then the cells die early, leaving a shortage of the healthy red blood cells. They can also, and it will, when they do that, it can cause blood flow. And that blood flow, that's a sickle cell crisis, because now you're blocking blood flow. You're going to start having potentially necrosis, ischemia. So, and it's very painful. The sickling response is reversible with adequate oxygenation and hydration, but after repeated sickling, the cell becomes permanently sickled. Obviously, somebody's in a sickle cell crisis. What do? We're going to hydrate them and we're going to give them oxygen, right? And pain meds, because they're going to be hurting. Interventions: maintain adequate hydration and blood flow, administer oxygen, administer analgesics, just like I said. Sickle cell, they have almost several pages about this in your book, so this is very, very summarized. All right, this is the last one we're going to talk about, thalassemia. This is an autosomal recessive disorder. It's characterized by the reduced amounts of hemoglobin and decreased number of red blood cells. It's higher in people of Mediterranean descent. Basically, treatment is supportive. The goal is to maintain normal hemoglobin levels. It may need to be done by blood transfusions, may need to remove their spleen to increase the lifespan of their RBC. Why would you remove a spleen? The spleen is known as red blood cell graveyard, right? That's where red blood cells go to die. So if you take away the spleen, they have nowhere to go to die. Okay, sorry, this was 1 hour. I hate doing lectures this long, but we're done. We got it. Thank you for hanging with me.